हेलो नारायण जी एकपटक चेक गरेँ मैले स्टार्ट गरिदिएछु हैन सबै खोल्दैछु चेक गरेँ सर डाक्टर साहब आइसक्नुभयो टाइम हुनेवाला छ चेक गरेँ के बन्द गरिदिउँ ए अलि स्लाइड ए यहाँ ल इसको यहीं रखो Good morning. So we'll be talking on nephrotic syndrome. So this is the facial puffiness that you see in any case of a renal disease. Okay, either chronic renal failure, nephrotic syndrome, nephritic syndrome. Okay, so this is the periorbital edema. So this is again the edema. Okay, pedal edema is there. Okay, and because of the edema, there is a blister formation over here. So what is nephrotic syndrome? So it's a proteinuria. The level is more than 3.5 gram in a day. Also, in the nephrotic syndrome, there is hypoalbuminemia. The albumin level is low, it is less than 3 milligram per dl or less than 30 gram per liter. So edema will be there. So generalized edema will be there. Hyperlipidemia is there. Okay, and lipiduria is there. So this is the nephrotic syndrome. What are the causes of nephrotic syndrome? So it can be idiopathic or the primary nephrotic syndrome, or it can be the secondary nephrotic syndrome, or the cause is secondary. So primary nephrotic syndrome, that means the disease is confined to the kidney only. So that is the meaning of primary nephrotic syndrome. So minimal change disease is there. Okay, focal segmental glomerulosclerosis is there. Membranous nephropathy is there. Membranoproliferative is there, and other proliferative and sclerosing glomerulonephritis. So this MCD, that is minimal chain disease, is most common is seen in the children. Okay, and this membranous, it is more commonly seen in the adult. So this is the most common cause of nephrotic syndrome in an adult. Okay. Secondary of the causes is secondary. So what are the causes? Diabetes mellitus can be there, SLE is there, and other collagen vascular disease is there. Some amyloidosis, vasculitis, immunological disease like mixed cryoglobulinemia, Wegener's granulomatosis, RPGL, polyarteritis nodosa, HSP, that is anorexia porphyria, sarcoidosis, Good-Passer syndrome. Okay, so these are the vasculitis syndrome. So Wegener's, SPAN, SSP, Good-Passer, these are all vasculitis syndrome. So they can also involve the renal vessel. So that leads to the development of the nephrotic syndrome. Infection like bacterial, like post-streptococcal, congenital and secondary syphilis, SBE, that is subacute bacterial endocarditis, viral causes like hepatitis B, C, HIV, infectious mononucleosis, CMV infection, parasitic like the malaria, toxoplasmosis, schistosomiasis, and filariasis. So these are the infectious causes of the nephrotic syndrome. Okay, so medication, certain drug that can also induce the nephrotic syndrome. These are the gold, mercury, heavy metal, penicillamine, NSAID, lithium, okay, trimethoprim, captopril, and the heroin. So these are the other causes. So what are the specific causes of the secondary nephrotic syndrome? Okay, so it can be hereditary and the metabolic disease like Talbot syndrome, Fabry, sickle cell disease, congenital nephrotic syndrome, familial Neil-Patella syndrome, and partial lipodystrophy. So these are the specific causes of the nephrotic syndrome. Others like the pregnancy related. In some cases of eclampsia and preeclampsia, you may also get heavy proteinuria. So transplant rejection is there, serum sickness, accelerated hypertensive nephrosis, unilateral renal artery stenosis, obesity, sleep apnea, and reflux nephritis. So these are the other causes of nephropathy. So this membranous glomerulonephritis, it is most commonly seen in the most common cause of nephrotic syndrome in the adult. Okay. Minimal chain disease. Most cases are primary or idiopathic. That means you do not know the cause of the minimal chain disease. Some secondary causes that can lead to the MCD, they are the use of the NSAID and the Hodgkin's disease. Common cause, it's the commonest cause of nephrotic syndrome in the children, comprises of around 70 to 90% of cases of nephrotic syndrome in children. It is present clinically with abrupt onset of edema, generalized edema. Less common picture are hypertension. So if the MCD is there in the adult group, okay, most of them they are having around 50% of them are having hypertension. So microscopic hematuria and function they are less common. MCD on the renal biopsy, so no obvious glomerular lesion by light microscopy. Or occasionally you may find a small amount of the IgM in the mesangium. So in the MCD, so I think there is loss of the podocytes. Okay, is there? The fenestra between the podocyte there, they are increase in the gap is very increased. So that's why there is proteinuria. So in the light microscopy, you may not see this lesion, but in electron microscopy, it is obvious. 30% are spontaneous remission. The treatment with steroid is recommended. Non-responder to steroids should be biopsy. Primary responder are those who have complete remission. Okay, so the complete remission is defined as less than 0.2 milligram in a day. So less than 0.2 mg per 24 hour of protein after a single course of the prednisone. Okay, so around 90% of children develop complete remission after 8 weeks of the steroid, while 80 to 85% of adult complete remission only after 20 to 24 weeks of steroid. So patient with steroid resistance can develop focal segmental glomerulosclerosis. Okay, in this case also the prednisolone is the first line. Other immunosuppressive agents are there that can be used, like the cyclophosphamide, prorambucil is there, mycophenolate mofetil is there, and they are safe for the frequent relapse of the steroid dependent and steroid resistant cases. Okay. So, second cause of this nephrotic syndrome, this is the focal segmental glomerulosclerosis. So as the name indicates, focal means and the segmental. That means the pattern of injury is characterized by segmental glomerular scars that involve some but not all the glomeruli. So these are the segmental or the focal glomerular scars that involve only some of the glomeruli but not all. Okay. So clinically FCGS manifests as proteinuria. So proteinuria should be heavy proteinuria more than 3.5 gram per day. So nephrotic range proteinuria and renal insufficiency associated with a poor outcome. And around 50% of patients reach renal failure in around 6 to 8 weeks, 8 years. So rarely this FSGS rarely remits spontaneously, but treatment-induced remission of proteinuria improves the good prognosis. Primary FSGS is most of the time it is due to the ACE inhibitor. Okay. Nephrotic rate proteinuria is steroid but respond far less than the patient with MCD. Usually around 20 to 45% of the patient with FCGS, they undergo remission in around 6 to 9 months after the steroid use. Okay. And the secondary FCGS, hypertensive nephropathy, hepatitis B related, reflux nephropathy, sickle cell disease, okay, Fabry disease. In this case, you have to treat the underlying cause of the disease. Okay, so if there is hypertension, you have to treat the hypertension. There's hepatitis B, antiviral drugs, sickle cell, hydroxyurea. Okay, so other third category is the membranous nephropathy. So it is rarely seen in children. It is the most common cause of this nephrotic syndrome in the adult. In most cases are secondary to the malignancy, hepatitis B, malaria, schistosomiasis, hematological diseases. So non-selective proteinuria is there. Microscopic hematuria may be found in around 50% of cases. Okay. So spontaneous remission seen in around 20 to 30% of cases. One third of the patient undergo relapse but maintain normal renal function, while one third progresses to the renal failure. So in case of nephrotic syndrome, don't think that you won't get any hematuria or this hypertension. There can be some overlap between the symptoms. So this is the membranous nephropathy and it is a cause of nephrotic syndrome. But you are seeing this hematuria. So hematuria and hypertension, they are feature of the nephritic syndrome. So in this case also, there is overlap of the syndrome. Okay. So in this case, spontaneous remission can be there in 20 to 30% of cases. Male gender, older age, hypertension and persistence of proteinuria, if it is there, it indicates the worst prognosis. Okay, highest incidence of renal vein thrombosis, this pulmonary embolism, and DVT is seen in this membranous nephropathy. Okay, prophylactic anticoagulant, the role is controversial, but is recommended for patients with prolonged proteinuria and in absence of risk factor for bleeding. Therapy with immunosuppressive recommended in primary membranous nephropathy and persistent proteinuria. So what workup you do in cases of this nephrotic syndrome? The laboratory study like electrolyte, blood urea nitrogen, creatinine level, calcium, phosphorus, and the ionized calcium level. The urine analysis is done for the hematuria, for presence of protein, for presence of albumin, okay, or any presence of RBC cast. So macroscopic hematuria is present in 20% of cases and cannot be used to distinguish from any forms of glomerular disease. The presence of macroscopic, that is gross hematuria, is unusual in this minimal chain nephrotic syndrome and suggests another cause such as MPGN or as a complication of idiopathic nephrotic syndrome. RBC cast, if present, are suggestive of acute glomerulonephritis. Urine protein quantification by first morning urine protein creatinine ratio or 24-hour urinary protein. Okay, so this if this level is urine protein creatine ratio is more than 2.2 to 3 milligram, it's consistent with the nephrotic range proteinuria. And if the level of 24-hour urinary protein, if it is more than 3.5 gram, then you can say it is a nephrotic range proteinuria. So it can be expressed in this also mg per meter square per hour. So if the level is more than 40 mg per meter square per hour, it also defines the nephrotic range proteinuria. Serum albumin is low in case of nephrotic syndrome. So because there is albuminuria, so that's why the level is very low. The value as low as 0.5 gram per dl is not uncommon. Lipid profile, it is elevated. The total cholesterol is elevated, LDL is elevated, TG is elevated, and SDL can be normal or low. So remission, urinary protein excretion, if it is less than 4 milligram per meter square per hour, or urine dipstick on is nil or trace for 3 consecutive days. If it is there, then you can say the remission has been achieved in case of nephrotic syndrome. So remission is most of the time, remission is achieved by prescribing the prednisolone. Okay. So what is the meaning of relapse? The urine protein excretion, if it is more than 40 or urine dipstick still shows 2 plus or more for 3 consecutive days. So if it is there, then you can say the disease has been relapsed. Okay. What is the steroid resistance? It's failure to achieve remission in spite of 4 weeks of standard prednisolone therapy. So failure to achieve for more than 4 weeks, then you can say it is steroid resistance. So how do you manage a case of nephrotic syndrome? So trial of corticosteroid is the first step in the treatment of idiopathic nephrotic syndrome or the primary nephrotic syndrome, in which kidney biopsy is not initially indicated. Thus, patient age 1 to 8 years with normal kidney function, without hematuria, no symptom of systemic disease. Okay, like systemic disease means like the fever, rash, joint pain, weight loss, and normal complement level, negative ANA, negative viral, and no family history of kidney disease. If it is there, you may consider for the steroid treatment prior to the kidney biopsy. So if it is there, nephrotic syndrome, if the age is 1 to 8 years, with a normal kidney function, no hematuria, no signs of any glomerulonephritis, okay, no signs of any immunological disease, it is there, then directly you can start the steroid before doing any kidney biopsy. Also, in the pre-adolescent age, like less than 18 years, okay, 8 to 18 years, in that case also, if these symptoms are not there, okay, like hematuria, they are all not there, then you can also start the steroid empirically before doing any kidney biopsy. So corticosteroid treatment in minimal chain nephrotic syndrome or idiopathic nephrotic syndrome does not require the initial biopsy. Okay. Induction therapy, first of all, you have to exclude any presence of infection or any other contraindication to the steroid therapy. Then start the prednisolone with around 2 mg per kg dose. So if the age, suppose if the body weight is around 60, then you can start with a 2 mg per kg per day. So it is given daily for 4 weeks. Okay, then traditionally the total daily dose was split into 2 doses. However, a single daily dose of steroid has equal efficacy to split the dosing and fewer side effects. So you can give this drug either in divided doses, that means 30 milligram in the morning, 30 milligram in the evening, or you can give a single dose also. Okay. Studies have shown that a longer 6 week rather than 4 week period of initial steroid treatment reduces the subsequent rate of relapse. So maintenance therapy, after this initial therapy, okay, then you maintain the give the maintenance therapy. So following above induction therapy, original guidelines recommend oral prednisolone at 40 milligram or 1.5 milligram per kg given as a single dose on alternate days for 4 weeks. Subsequent studies demonstrate that a longer alternate day maintenance period of 6 weeks resulted in a lower rate of relapse. Okay, so following 6 weeks of alternate day treatment, steroid may be stopped or slowly tapered over a variable length of time. Okay, so an assessment of the Cochrane database concluded that after the initial daily steroid induction phase, continuation of alternate day steroid for around 6 months could reduce the subsequent relapse rate by 33% compared with the shorter alternate day treatment. So this is the data from the Cochrane. So they suggest that longer duration of the steroid therapy, alternate day steroid therapy, is more beneficial in preventing the relapse of the case of the disease. So what is relapse? So frequently relapsing nephrotic syndrome and steroid dependent nephrotic syndrome. Frequently relapsing nephrotic syndrome is defined as steroid sensitive nephrotic syndrome, that is SSNS, with 2 or more relapses within 6 months or more than 3 relapses within 12 months of the period. So this is the meaning of steroid sensitive nephrotic syndrome. Okay. This SDNS, that means steroid dependent nephrotic syndrome, is defined as this SSNS, that means steroid sensitive nephrotic syndrome, with 2 or more consecutive relapses during tapering or within 14 days of stopping the steroid. So this is the steroid dependent nephrotic syndrome. So relapse therapy for infrequent relapses, steroids are resumed, although for a shorter duration than the treatment during initial presentation. So prednisolone dose 2 milligram per kg per day, given as a single morning dose, is administered until proteinuria has resolved for at least 2 days. Following remission of the proteinuria, then prednisolone is reduced to 1.5 milligram per kg, given as a single dose on alternate day for 4 weeks. Steroid may then be stopped or gradually tapered. So you can also use diuretic because there is presence of edema. So loop diuretic is preferred. Okay. So furosemide is there. Okay, 1 to 2 milligram per kg per day are safe and moderately effective. When a patient present with anasarca and signs of intravascular volume depletion, you can also use 25% albumin. Okay, so albumin infusion can be done. Okay, although it is controversial, but it is useful. So given at a dose of 1 gram per kg body weight, given as a continuous infusion over 24 hours. IV albumin may be particularly useful in diuretic resistant edema and in patients with significant ascites and or scrotal or labial edema. So albumin is beneficial, particularly if there is diuretic resistant edema and there is significant ascites or any scrotal edema. So antihypertensive therapy, particularly the thyroid, this ACE inhibitor or the ARB, so they also contribute to reducing the proteinuria, but should be used cautiously in the presence of acute renal failure. So ACE inhibitor or the ARB, they cause decrease in the proteinuria. So this agent is also prescribed in the treatment of nephrotic as well as nephrotic syndrome. So for frequently relapsing nephrotic syndrome and steroid dependent nephrotic syndrome, the clinical evidence is inadequate to support the preferred method of treatment. Therefore, it is said that the practitioner must rely on the clinical experience and discuss the potential advantages and disadvantages of each treatment with the family and the patient. So, alkylating agent like cyclophosphamide, chlorambucil, nitrogen mustard offer the benefit of possible sustained remission after a defined course of treatment. So cyclophosphamide for the resistant cases or the relapse cases is given in a dose of 2 to 2.5 milligram per kg daily, orally for 8 to 12 weeks. So steroids are usually overlapped with the initiation of cyclophosphamide and taper. Chlorambucil can be used in those patients who subsequently relapse after treatment with cyclophosphamide. Other agent is the levomethasone. It is an anti-emetic drug that has immune modulating effect and can be effective in reducing the relapse rate in frequently relapsing nephrotic syndrome. So the dose is 2.5 milligram per kg given on the alternate day. Other agent is mycophenolate mofetil. So although small studies have shown MMF to be effective in the reducing the number of relapses in frequently relapsing nephrotic syndrome and steroid dependent nephrotic syndrome, adequate randomized control trial still need to be performed. MMF have been found to be useful steroid sparing agent in stable patient. Stable patient means those without having excessive edema, need for hospitalization, or without any other serious complication. So, what are the complications associated with the nephrotic syndrome? It can be infection. So, immunity is less, immunity is decreased, so chances of infection is there. Sepsis is there. Thrombosis, so hyperlipidemia is there, and in particularly in case of membranous glomerulonephritis, in that case, there is increased chances of pulmonary embolism, DVT. Okay, hyperlipidemia is also a complication. Acute renal failure, some patient can go into a stage of acute renal failure. The side effects of the drug. So complication associated with the side effect of the drug. Because this corticosteroid, this all agent, they are used for longer duration. So that's why they have got side effect. So corticosteroid can lead to the development of infection. So immunocompromised state is there. So infection is there. Osteoporosis can develop. Okay. The chances of edema is there. Okay. So diuretic, albumin, cyclosporin, they all have got the side effects. So this is all about the nephrotic syndrome. Okay. Thank you.
Thank you, sir.